Thanks everyone for joining us. Good afternoon, evening, middle of the night as it may be. All right, Austin, I'll just go ahead and get started while you're admitting people. Does that sound all right?
Yeah, please go ahead.
Okay. Great. Well, thank you. Hello, everyone. Thanks for joining us for this pre-application technical assistance webinar for the Global Alliance for Chronic Diseases program. I will be calling that GACD throughout the webinar today. And this webinar is on our two new NOFOs entitled Implementation Research for Multimorbidity Management in the context of non-communicable diseases in low and middle income country and U.S. tribal populations. I will be calling it all together the GACD Multimorbidities NOFOs because it is really a mouthful. We have those two PARs listed there, which we'll talk a little bit more about. But first, let me introduce myself. My name is Amanda Nguyen. I'm a program officer with Fogarty. I'm joined by my colleague, Dr. Brad Newsom, who many of you know, another program officer. And then Austin is in the process of admitting you all, Austin Downs. And he is our program manager who will be providing any technical support as the meeting goes on. So I'm going to go ahead and take the lead on giving a brief overview. And I will try to keep it brief, so there's plenty of time for questions, but I'll give a brief overview about what the GACD is and kind of the motivation for both the GACD as a whole, and then to talk a little bit more specifically about the current funding calls so that then we can dive into the questions and answers that you have. I'll give the webinar slide presentations, and then we'll pull Brad in as the lead on the Q&A as he is the knower of all. So first off, just a little bit about GACD. This particular audience, you all on this call, I probably don't even need to talk through this slide with you, but I will. Currently, the situation as we know it, 63% of annual deaths are from NCDs. That translates to about 36 million people dying each year. And we know that there is increasingly an excessive burden of those deaths in low and middle income countries, where 80% of those deaths are now experienced in those LMICs. So the GACD has really been brought together as a partnership of many of the leading global health funding agencies to really start to tackle this problem, and specifically through an implementation science research perspective to really think about how we can improve care, how we can improve patient outcomes for these folks. We have at the GACD already funded over 1,200 researchers, I think it is, maybe even over 1,300 now, over 180 projects. And across it all is this mission to reduce the burden of chronic NCDs in LMIC countries and in First Nations populations in high-income countries facing conditions of vulnerability by building evidence to inform national and international policies and to contribute to the achievement of the Sustainable Development Goals. So as I said, together the 15 members, the funding agency members that comprise the Alliance, represent 80% of the global public funding for health research. So it's really exciting to be a part of. You can see here the various GACD associate members that are included in the GACD Alliance. And to talk a bit about where we came from, so starting back in GACD was conceptualized and launched around 2010 with the first funding call in 2012. And those first series of calls were really disease specific. So hypertension, diabetes, lung diseases, mental health. There was a call focused on scaling up some of the work that had been done, and then a focus on cancer. And around 2021, GACD began to pivot toward more of a cross-cutting approach to address some of these issues impacting NCDs. So the first in that new kind of cross-cutting strategy was a life course call. And then our most recent one was healthy cities research. So really focusing on the built environment and how that can be leveraged to improve health and address NCD risk factors. As I said, over the life course of the GACD, we have funded many, many projects across all of those different partners. NIH alone has funded over 40 projects to date, representing around 145 million in NIH investment. Now, this program, I'll say this a few times, Fogarty does not fund directly for this program. We manage this program for all of NIH. So it is a real trans NIH program. There are a number of institute and center partners, IC partners, that are involved in this program. You can see listed at the bottom there different partners that have been involved: NHLBI, NCI, NIMH, NIA, NIDA, NICHD, NIMHD, NIEHS, NEI, and ODP. So when you're starting to think about putting together your proposal, you're really wanting to think about where it fits with the priorities of one of those centers, because Fogarty will not be the one funding and managing your award. That history brings us to the current NOFOs that are focused on multimorbidity in the context of NCDs. So first off, when I say NCD multimorbidity, what we're talking about here is the co-occurrence of multiple long-term chronic conditions, at least one of which is an NCD. I know there were a number of questions in the first round of this webinar around what that means. So, it could be, for example, another long-term chronic disease and hypertension or something, HIV, hypertension among people living with HIV, or, various, we leave it really broad in terms of kind of your proposal around how to conceptualize that. And we're happy to field questions about that during the Q&A portion of this. But one of those long-term conditions would need to be an NCD. The reason why we want to focus on this right now is NCD multimorbidity is rising, and it has a profound impact on patients and patient health outcomes, and really causing strain to healthcare systems. And it's very difficult to address this in a fragmented care model. So really needing to shift from fragmented care into an integrated holistic care model. But we know that there are challenges to doing that and challenges to implementing these patient-centered strategies for addressing NCD multimorbidity, particularly in health systems that are not where most of the research has been done. So there has been much research done about implementing patient-centered strategies, but most of that has come from high-income countries. And so we're really wanting to support research, looking at adapting and scaling models to improve quality, to reduce disability, to reduce the burden of caretaking, and reduce those system costs in low middle income countries. That brings me back to the title, which I've already said once, so I won't say it again. The GACD multimorbidity call. This is the most recent now in our series of GACD sponsored calls. There are two mechanisms. They both have the same focus. I will go into, in a couple of slides, I'll go into more of a detailed breakdown of PAR 25213, which is an R01 Clinical Trial Optional, and PAR 25223, which is a biphasic R61 R33 Clinical Trial Required. I'll go into more details. But both of them have many of the same features. Both of them, to be eligible, the primary applicant needs to be a U.S. institution or a World Bank classified LMIC institution. The awards are meant to be 5-year awards funded at $500,000 per year per award in direct costs. Again, noting that FIC does not directly support these awards, but manages this program. So applications to this program will be reviewed through a special emphasis panel that CSR, the Center for Scientific Review, pulls together. And how awards are selected is that the different institutes and centers will fund meritorious awards within their R01 or R61, R33 pay lines, or through select pay. And again, we can answer more questions about that. The purpose here, again, is really to focus on implementation research. So we're looking to support studies that will generate evidence about when, for whom, and under what circumstances those patient-centered approaches can improve integrated care for patients with NCD multimorbidity. This is specifically in LMICs and American Indian, Alaskan Native populations in the US, with the potential to equip policymakers and practitioners with evidence-based strategies to improve care. Implementation research is so central to this program. We really want to maintain the focus on it, which is why I'm saying it many times. The NOFO is aligned with the overall GACD initiative to support implementation research. We consider that to be the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings to improve individual outcomes and to benefit population health. So really looking at which strategies work for whom, under what circumstances, to promote the uptake, the scale, the spread of effective interventions, to look at how interventions can be adapted and scaled up in different contexts. And this, again, is so important in LMICs, where we have different interventions that we know can be effective, but really need to figure out how to fit those into health systems to ensure, good use of limited resources and investing in cost-effective interventions. If you do need to look at resources around implementation research frameworks to help ground your study, we have some links here. These slides will be available on the website. I would direct you specifically to the last one. It's a Fogarty website in which we provide an implementation toolkit that might be really helpful. So please do take a look at those and remember to ground your application in an implementation research framework. So a little bit about these two different mechanisms so that you can choose the right mechanism to target your application to. I'll be talking first about the similarities. Both of these mechanisms are really generating that same evidence that I just talked about that implementation research for whom, under what circumstances, interventions will improve care. Both should describe the study population, a life course approach, use of evidence-based interventions, use an implementation framework, describe efforts to address health equity, include implementation research outcome measures, describe stakeholder and community engagement. Also very specific to all the programs we support at Fogarty, we really want you to address implementation research capacity building. I can talk a little bit more about that. And equitable partnership and governance. So that, regardless of which you design your application for, all of those are the same. We do require LMIC or AIN institutional leadership or partnership. What that means is if there is a U.S. institution as the lead applicant, you really need to have a partner in one of those institutions, and you need to have researchers in key roles, MPI, key personnel roles. If you're applying from an LMIC institution as the lead applicant, you do not, but you could choose to, but you do not have to have a U.S. partner. So it's a little bit different based on which end of that you're applying from. And there is an emphasis, just given the cross-cutting nature of the work, on multidisciplinary projects. Here's where the differences come in. So the R01 Clinical Trial Optional, the PAR 25-213, is kind of your standard R01, 5 years, $500,000 a year in direct costs. If you propose a clinical trial, you need to include milestones, but not for non-clinical trials. And many of the participating ICOs have signed on to the R01. That would include those listed there: NHLBI, NIMH, NEI, NIA, NICHD, NINDS, and the Office of Research on Women's Health, ORWH, is interested in co-funding awards of relevance to them. Make sure you check out in the NOFOs. You can read the IC specific funding priorities so that you can see what they're valuing in and prioritizing in the research that they're trying to fund. Now, for the R61, R33 Clinical Trial Required, the PAR 25-223, this mechanism is a little different. The 5 years are broken up into a first year R61, that's 1 year at $500,000 a year in direct costs, and then a potential transition to an R33 for up to 4 additional years at that same $500,000, contingent on meeting milestones for transition. So at the end of the R61 period, there would be an evaluation about whether milestones had been met, and you need to include those milestones in your application. There are fewer ICOs that participate in this mechanism. Those include NHLBI and NIMH, and again, ORWH is interested in co-funding. To clarify, for ICOs that are participating in both mechanisms, you would want to use the R01 Clinical Trial Optional option for non-clinical trial applications. You would want to use the R61, R33 if you're proposing a clinical trial. So if you have questions about that, again, we can answer those questions in the Q&A section. And if you have specific questions about where your research might fit, you're also welcome to reach out to any of the points of contact that are listed for each of the ICs in the NOFO. For those of you that may be putting together an R61, R33 application, let's talk a little bit more about those transition milestones. So here are some questions that you can ask yourself when you're really thinking about what makes sense to propose in terms of transition milestones. So first, are they well-defined with quantifiable measures that are appropriate for assessing the success of the R61 phase? Do the milestones have specific quantifiable criteria that will enable clear decision-making about their attainment? Remember that someone has to review these to make a determination of whether to advance your award to the R33. Is it clear how the R33 phase would develop and expand once the R61 milestones are achieved? And given the potential benefits of the proposed research, do the milestones support transition, and will the overall project advance the intervention? So again, if you have specific questions about what would be an appropriate milestone, please do reach out, or we can talk further in the Q&A. But that is a really important piece to be thinking about in that phased R61, R33 version of this NOFO. Something else that we want to make sure that you look at very carefully are non-responsiveness criteria to ensure the alignment of your application with our program expectations. We're highlighting here some of the key non-responsiveness criteria. There are others. They're all listed in Part 2, Section 1 of the NOFO, so please do look at those very carefully. Briefly, applications that are not focused on evidence-based interventions for NCD multimorbidity that do not justify the choice of the interventions or provide evidence of their effectiveness, acceptability, feasibility, those would not be responsive. So we really want you to be looking at using an evidence-based intervention. Applications that do not focus on implementation research or hybrid effectiveness implementation research. So for example, if your application is merely formative work that will inform the selection of an intervention for a later proposal, that would not be responsive, nor would just be straight evaluating the effectiveness of an intervention without any attention to implementation outcomes. All proposals really must contain a plan to implement and or scale up, and really be looking at implementation outcomes. Applications that do not propose implementation research capacity building for LMIC and or AIAN researchers on the research team would not be responsive. We really want to make sure that through this research program that we are also supporting capacity building. And that feeds into, of course, our focus as well on equitable partnerships and ensuring that applications are demonstrating equitable partnerships and shared leadership between the leaders across the different institutions that are involved. So applications that do not demonstrate that equitable partnership would be considered non-responsive. Again, please take a very careful look at that. And if you have questions about responsiveness, reach out to points of contact. Just a few other things to highlight across both of these. NIH has issued the data management and sharing policy to promote sharing of scientific data. Under this policy, investigators and institutions are expected to plan and budget for the management and sharing of data, submit a DMS plan for review in their application, and then comply with that plan. And you can see on the website examples. There's a link here for an example of a DMS plan, but that is something that needs to be addressed in your application. Likewise, if you are proposing a clinical trial, please do look at the NIH clinical trials policy. You can use these 4 questions to determine if your study is a clinical trial, and those would be, does the study involve human participants? Are they being prospectively assigned to an intervention? Is the study designed to evaluate the effect of the intervention? And is the effect being evaluated a health-related biomedical or biobehavioral outcome? I mentioned that these will be reviewed through a special emphasis panel. There has been, there will be in January 2025 a move across NIH to the simplified review framework. And so this receipt date will come after that change. And so this slide here describes how applications will be reviewed. They will be reviewed according to three core review factors. Factor one is the importance of the research. So that includes the significance and the innovation, which are scored from 1 to 9, exceptional to poor. Factor two is rigor and feasibility. So that includes the approach. And that would be, again, scored with the same 1 to 9. And then factor three is the expertise and resources. That includes the investigators and the environment. That one is not scored from 1 to 9, but is instead evaluated as whether it is appropriate or whether additional expertise and resources would be needed, and reviewers would need to describe what gaps there are. All of that will go together into the overall impact score, which again is scored from 1, exceptional, to 9, poor, in terms of assessment of the likelihood for the project to exert a sustained, powerful influence on the research. And also in consideration of other score driving factors such as milestones, study timeline, human subjects inclusion, vertebrate animals, biohazard, and resubmission. Again, look at this closely in the NOFO. It's section 5, application review information, and make sure you do understand because there have been changes or there will be changes for this review. That is the end of my very quick overview. I wanted to leave as much time as possible for questions. I'm going to stop screen sharing so that I can see the chat with all the questions, but we can put slides back up if we need to for reference.
Thanks, Amanda, so much for that overview. And perhaps we can take a multiple approach here where you can either raise your hand and you can unmute, or you can put your question in the chat. Both options are fine. So we're going to do a back and forth between Amanda and me for fielding questions and getting you the best answers that we can provide at this point. We do have a couple questions coming in, but again, this is meant to be an engaged discussion around this program. So if you do want to raise your hand and take yourself off mute, we can also do that or utilize the chat function.
And the questions that arose out of the first sitting of this webinar and the questions from this, we will be consolidating those and we'll be posting all of those on the website as well. So make sure you keep an eye back on the website because we'll have those answers there for you. So I see the first question that came in for a clinical trial under NHLBI, this has to be the R61, R33 option. Is that correct? It cannot be an R01. Brad, do you want to take that one?
Sure. So you are correct. NHLBI and NIMH for this call are utilizing the R61, R33 for all of its clinical trial work. So, and there is further information in the funding opportunity in the IC specific language section around when you use the R01 option versus when you use the R61, R33 option. For the other institutes that are not participating in the R61, R33, they allow, and you will write clinical trial applications or non-clinical trial applications, both to the utilizing the R01 Clinical Trial Optional NOFO. Only NIMH and NHLBI are utilizing the R61, R33 for their clinical trials. So you are correct, but for those of you who are considering the applications that are germane to the Heart, Lung, and Blood Institute or the Mental Health Institute, it's going to be really important for you to have discussions with the points of contact that are listed at the end of the funding opportunity to make sure that you are getting to the right funding opportunity, the correct NOFO that will matter significantly when you submit your application. So be mindful of that. Set up a call with the points of contact at those two institutes. For the other ICs, you will submit everything through the R01 Clinical Trial Optional NOFO.
And could you also, Brad, speak a little bit more about the life course approach expectation?
Sure. So this is, and I don't know how many of you who have been following the GACD program broadly over the last years, but 4 years ago, we launched our call around 3 years ago, leveraging the life course approach to our work, whether that is starting early to prevent or manage NCDs in adolescence, all the way through from an early stage of life all the way through the end of life stages. That does not mean in any respect that you need to focus on the entire life course, but being mindful that much of management, much of prevention. Now, of course, this funding call is really focused around multimorbidity management in people that are already dealing with multimorbid conditions. But many of our calls over time have been both management and prevention focused. And when we say that we care about a life course approach, it's understanding that many of our programs or interventions to get the best outcomes, they may need to start before development of symptoms, development of multimorbid conditions, for instance. And that's why we've taken a life course approach, not only through GACD, but then also across NIH, where there's specific requirements within our funding opportunities to provide clarity around the stage of the life course that you're focused on and being mindful of the connections across the life course. So hopefully that answers your question. If you need more information, again, we are here to answer some more questions where we can set up calls to really dig into some of the more specific minutia of your ideas for your research application.
I see another question, which is about NCI not being listed, and I am reminded that I was meant to change that slide. So yes, thank you for catching that, and my apologies for the gap. NCI is participating, and it reminds me each time to say, at the end of the day, make sure that you are going with what is written in the NOFO. And if there's any question about something that we say in this webinar that's different from the NOFO, double check with us or adhere to that NOFO, what's written down there. So yes, NCI is participating, and that was just a glitch on my slide. Curtis asked a question. We're planning to study Pacific Island populations. Is that allowed as a First Nation group? And also, is it allowed to go above the 500,000 yearly cap?
Okay, so first off, 500 cat. Just like with all of our R01 clinical trial required, clinical trial optional programs at the R01 level, you are allowed, and there's a section in the NOFO further down that says if you are going to request more than $500,000 in direct costs for any 1 year of your application, you do need to reach out 6 weeks, at least 6 weeks in advance to the institute that you're planning to apply to and get their written approval to put in an application above the 500,000 direct cost cap. You are allowed to do that. That does not mean that they're required to grant it. But when you're reaching out, it's going to be critical for you to have quite a bit of clarity around your general specific aims, the intent of your work, and why the work that you're proposing cannot be done under the $500,000 cap. So you can get further information from the points of contact that are listed at the end of the NOFO based on if you want to apply to do mental health research. The mental health contact is in there, and you need to reach out at least 6 weeks ahead of time to get that in writing confirmation that you're allowed to put in an application over $500,000. So always remember that. Remember that 6 week or the 6 week cutoff. For Pacific Islander populations, there are a couple different ways that you can look at this. We specifically call out Alaskan Native and more American Indian, more continental folks. It's more to maintain alignment across multiple programs. We do allow for work with Native Hawaiian populations and other Pacific Islanders, but it's important for you to be mindful of how you're putting that in. If you were dealing with Pacific Island populations that are part of an LMIC that are not, U.S. protectorates, either Hawaii or the Marshall Islands, Guam, things like that. Those would be part of the U.S. and you're doing work with that along with the AIAN population. If you're looking at doing Pacific Islander research outside of Hawaii and the protectorates, then it would be considered a global LMIC based research where you'll need to have a very invested LMIC partner at an institution in where you're wanting to work. So, but if you're wanting to work with native populations in New Zealand or in Australia, then those would not be considered responsive to this funding announcement, but New Zealand and Australia do support research through GACD for more First Nations populations on their islands or continents. So be mindful of how you're defining the Hawaiian or the Pacific Islander populations, and we can discuss this in more depth on a more directed call, but that's how we'll approach it for this.
Great. I see a few more coming in. I wanted to go up to one I only answered part of. So supposing midway through a project, it's planned that a clinical trial would be helpful to generate more evidence. Is that acceptable? So I think that's a question is asking about a change in your clinical trials designation midway through a project.
Yeah. That has become more and more difficult over time within NIH. We have quite a bit more stipulation on, and we're even past the grace period. If you put in an application that you say is not a clinical trial, but it is deemed to be based on those 4 questions that Amanda was going through with you earlier on, and it's deemed to be a clinical trial, even though you have marked it as not a clinical trial, it will be removed for non-responsiveness and not reviewed. We have fewer flexibilities than we used to have with these changes in scope, especially between non-clinical trial and clinical trial designations. So while you need to talk to the NIMH point of contact to really dig into the nuances here, if you are proposing a potential clinical trial, it needs to be there from the beginning. It's very difficult and nearly impossible to change that designation mid-course. I know sometimes, based on the information we're gathering, that it's quite germane to make that change. But we consider this such a significant change in scope that it's almost necessary to re-review an application, and that's why that transition almost never happens.
Great. I'm going to skip down one question. I'll come back to it, Roberto, but there was a question that was a follow-up for you, Brad, on your comments about the life course that we wanted to clarify a bit more. So describing the life course, but the language in this NOFO says to focus on care for people living with multiple long-term conditions. So this looks more like a multimorbidity management, already suffering with multimorbidities, whereas life course perspective seems to suggest a focus on prevention. So can you talk a bit more about that?
Sure. And you are very correct that this call, while many of our GACD calls over time have been focused on prevention and management. Now, we can certainly do some level of prevention of a multimorbid condition in its transition to a much more severe. We discussed earlier today at our session this morning around there are many stages of diabetes, for instance, and managing managing diabetes in some respects involves preventing its progression to much more serious conditions within the total lens of type 2 diabetes. So in that respect, it is a preventative measure for prevention of escalation within its management focus. But generally for this call, we really are focusing on how do you deal with the very complex nature of managing multiple long-term conditions, multimorbidity over time. And you are correct that this is not going to be a call that, for instance, in many situations, will deal with adolescents prior to development of multimorbid conditions. That doesn't mean that it can't exist. We deal in many respects with the long-term ramifications of a chronic illness in people living with HIV. We deal quite often with not just the management of cardiometabolic disorders or mental health disorders in this prime, 30 to 50, 60 element of life, but also taking into account end of life care for multimorbid conditions looks very different than dealing with someone in the 30s or 40s. So we're still looking at our importance placed on looking across the lifespan and not just honing in on we only really want to try to drive management in within a very finite age range. We are still acknowledging that the entire life course matters for management of NCDs, even though you are correct of the management focus of this call, more so than prevention. Make sense? Hopefully.
Excellent. And I saw a thumbs up, so I think that went through.
Okay.
So going back up before I move on, so would a multi-country application be feasible for this type of NOFO, say tribal nation USA and indigenous groups in another country in Latin America?
Absolutely. You don't need to have groups both in so, and I think that there's been some confusion on this along the way because of the nature of this. The title saying in LMICs and tribal nation populations, there's been some confusion along the way that we're requiring you to do work in both places concomitantly, and that's just not the case at all. It's a language issue there. You can absolutely do everything within an LMIC. You can do everything within a tribal population in the U.S., and that does not just include on reservations or within a localized tribal nation population, but within tribally affiliated groups all around the country. So you can look at Alaska Native population in New York City if you want, but still focusing on these critical AIAM populations, or like we were discussing earlier with Pacific Islander. So you can still do that, but doing a comparison, some people may be very interested in looking at a comparison for how you deal with Hispanic populations on both sides of the Texas-Mexico border, for instance, and having work going on in Mexico and having work going on in Texas. That is still feasible because you've got the LMIC partner there. You can still focus on a tribal population in the US with a completely different tribal population in South America, for instance. That is perfectly feasible to do. It's just making sure that the complexity doesn't get so large that it doesn't seem feasible, especially for reviewers. And more broadly, the conversations that many people have around how many countries should be involved in my research, it's a very appropriate discussion. Sometimes you want to look at an entire region of the world and looking at how you can scale an intervention across a region. It's perfectly fine to have multiple countries represented. You just need to make sure that you're being very clear when you're writing your application, especially through the lens of reviewers, that it's going to come across as feasible.
I see that there were a couple other questions about these population characteristics. So I'm going to skip down to just link those. So the first one was, can we include tribal populations in LMICs? And yes, the answer would be that
Yes.
populations in LMICs would be included. I
Yep.
don't, you want to say
Correct.
anything about that?
Yes, correct.
Yeah. And then a second question, what about focusing on veteran Pacific Island groups? Is that allowed?
Veteran Pacific Island groups, and it depends on what you mean. Are we talking about Guam versus are we talking about other nations that are not affiliated with the US? And that would change things in some respects. But this is still a life course approach. You can still focus on veterans. You can still, but because this call, unlike many of our calls, allows work with tribal nation populations, and we don't have more specific call outs to Pacific Islanders because they historically haven't faced some of the same barriers to care or significant disparities that some of the AIAN populations have dealt with. It's not been the same. And that's why there aren't more specific call outs to the Pacific Island nations and inhabitants in the NOFO like AIAN. But we can still address it, but as long as you're very clear on the 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 focus of the NOFO, the focus of the GACD program, focused on health disparaged populations, not just, for instance, wealthier veterans that just happen to live in Guam, but more actual Pacific Islander populations that have dealt with health inequities and disparities over time. So if you have further questions on that, again, these are some nuanced areas that are not as clear cut. So it's going to be critical for you to have conversations with either Amanda or me, or with the point of contact at the institute that you're considering applying to.
Excellent. And I would just tag on to that. Remember, there is also that focus on implementation research capacity building and also those equitable partnerships that we've highlighted a couple of different times. And so that might be a helpful thing to think about when you're kind of considering the population that you're proposing to work with, and whether that fits is there a partner group that you'll be working with, a partner institute, and how would you be conceptualizing implementation research capacity building in that? So if that kind of helps you kind of think more broadly around those really minutiae population questions, that might be helpful. I want to go back up before I lose it. For a study that includes both people living with and without HIV, would the AIDS deadline be used because it includes HIV in the application?
Correct. Yes, it would.
Yes. And then scrolling back down, does obesity classify as a condition or a risk factor that would be included in multimorbidities?
So this has been a discussion that we've been having for years, not only within NIH but across GACD as well. And I think at this point we are considering this as a chronic condition, and especially considering the multimorbid factors of cardiometabolic disease disorders that almost always align with obesity. Now, you've got interesting populations, say within India, where you don't have overweight people are dealing with type 2 diabetes but not overweight, so their cardiometabolic disorder is not tied to weight, which is a really, really interesting subset of population anyway, with type 2 diabetes, for instance, in a population that doesn't have obesity. But by and large, looking at obesity paired with cardiometabolic disorder more broadly, or with infectious diseases or lung health, whatever you want to do would be considered germane to this call.
Great. Following up on the earlier explanation, does comparison across multiple LMICs, such as SSA countries, constitute an advantage in terms of application review? Or does a single country project stand an equal chance of selection? And it depends. But Brad, I'll let you answer that it depends.
It's always an it depends. And really, I wouldn't say that there's an advantage either way, frankly. I have seen we have funded so many grants that look more broadly either at multiple country sites in multiple countries or multiple sites across one single country. We've funded all kinds of work that deals with just implementation of something within a single site in a single country. And I don't really find that there's a specific benefit from what we fund with either. And of course, it's always and it depends, but I don't think that you should be looking at this as if I don't have three countries of people represented, it's not going to stand a good chance in review. That's just not what happens in reality.
Yeah, I think it really comes down to, are you telling a compelling story about why you've chosen one approach versus the other? And that's where I think the it depends comes in, is, really thinking about that feasibility piece, and also the significance, right? And so just it's very hard to answer a question like that because it's just going to really be based on your application. So really think about, don't try to strategize it or gamify it one way or the other, but do what makes sense in your context and for your study.
Yeah.
Yeah. Given all the contextual factors in the implementation process, and maybe more messy to have more than one country, but non. Oh, you're answering that too. Thanks, Roberto. Yes, exactly. Yours is probably better than mine. There you go. More questions. Let's see. Have I missed any up here?
And certainly, if we are an engaged team, I think you can tell between Amanda and me, we are very happy if you want to put up your hand and ask a question directly versus putting it in the chat. We have options.
I'm trying to think of a couple of questions that came up earlier. Austin, you might have the list as well. I'm just trying to think if there's anything that came up earlier.
I would say that often we have questions of um, fit with specific institutes, especially on a call like this, where you're going to have multiple multimorbidity, multiple long-term conditions. You may be looking at people living with having cardiometabolic disease and obesity, and you're looking at their mental health outcomes. There are a lot of different areas of overlap between the partnering institutes that are here. You do have a form within your application associated with an assignment request form to say, I believe that my research fits best with this institute. Now, we convene a special emphasis panel each year to review all of these applications together. So you're not going to get a different review if you put it into NIMH versus the National Institute on Aging. Everything's going to be reviewed together. So there's not a review difference with this circumstance, but there is strategy involved. For instance, it's often very valuable time spent to look at some of the strategic visions that the participating institutes have. And for instance, the National Institute on Aging, and really putting a huge amount of appropriated funds into Alzheimer's research, for instance, just as an example. And their pay lines may be at a certain level, say 15%, but their applications that are dealing with Alzheimer's are at 25. I'm making up those numbers completely, but there is some strategy to be played here when there are this many options, and you can certainly talk with your program officers. Some institutes have very low pay lines. Be mindful of what that is. Do your research. Understand the strategic plans and the vision for what they're prioritizing for funding. That is part of the application process as well, making sure that you've done your research and giving yourself the best opportunities to get funded. You also can list primary and secondary institutes. Remember, Fogarty is not one of those institutes that you can apply to. But when you're thinking of this, make sure that you're very mindful that grant writing is not just all about writing a great grant, but doing your homework associated with understanding what people are prioritizing, both at the institute level and within the IC specific language within the notice of funding opportunity that really highlights some of the areas that each of the partnering institutes and centers are prioritizing.
Okay, so a couple of questions in the chat have reminded me of other questions from earlier. So I'll pose the next one, which was, can you talk a little bit more about the capacity building expectation? Are there examples of activities? That reminded me earlier, we put in the link an example of the GACD website has all descriptions of different projects that have been funded. I'm going to put that in here just so you all can see it as well. But then, Brad, I'll turn it over to you to talk a little bit more about capacity building.
Sure. And please look at not only the NIH website, but the GACD website as an incredible resource. GACD highlights every grant that has been funded, not only by NIH, but across all of the 15 funding partners. And it has an incredible trove of information that will hopefully benefit you as you're thinking through your ideas. It's not just a Fogarty goal here. Every Fogarty program, Fogarty-led program, even though this is a trans NIH program, but Fogarty plays this leading role in the development of the funding opportunities and its management. Every program that we launch has some level of capacity building, and that's the same as GACD. GACD highlights both flexibility in what capacity building means, but still a requirement for it. And if this were an institutional training grant, an international institutional training grant, a D43, if this were a T32 program or an F program or even a career development K award, there are very specific ideas around what constitutes capacity building. Not when we have research programs, though. We require some level of capacity building, but we give quite a bit of flexibility as to what that means contextually. So when you're developing your ideas, some people will want to be not only preparing early stage investigators that are doing research toward a PhD, some people will be wanting to also really equip community health workers to be able to get out into the community and be the front line of research data collection. There are various kinds of capacity building that you can do at community level, at medical level, but it still has to be through. If you were just saying, well, we're going to support people getting trained to be physicians, well, that's not research. We do still have a research focus, but that is broad. And you just have to give us a compelling argument as to why what you're doing is appropriate research capacity building. And this is going to be very contextualized. That's why, very strategically on our part, there is not much information in the NOFO around what we constitute as research capacity building. We want to give you infinite flexibility to meet your contextualized needs, even though if you don't have a plan there, we are going to kick it out and it's not even going to make it to review. It is that important to us that something is there that is going to meet your longer term needs, not just your research project right now. We care about building out a cadre of incredibly informed people to push this work forward. It is that important to us that if it's not there, we won't even review it.
Thanks, Brad. I think you kind of already in that answer addressed this other question about integrating implementation capacity building alongside the work. I think maybe we would just add to that we would want to know, maybe you could talk, Brad, about kind of a look at sustainability or how this would feasibly continue to be implemented after the project ends.
Yeah, and I also encourage you to look back on that GACD website. We have incredible toolkits, both here at NIH, but then also we have GACD is part of something much bigger. It's not just you getting an award. You become part of the GACD network, which is very broad, very informative, and works together with people all around the world to solve common issues, common challenges. And that's why this program is so much more unique than just yet another research award on just another R01. You become part of the GACD network. And that includes things like our eHub that provides huge amounts of information for implementation science training. We have master's classes, we have implementation science trainings from the beginning. So all of that is also available to you. If we wouldn't want, for instance, to be dedicating a research award to building implementation research training modules, for instance. This is not a training award. But integrating implementation research capacity building, absolutely. It's really critical. You can have a lot of different elements as to what that means, but you also don't have to reinvent the wheel. There are many resources that you can leverage through GACD and through this broad network that's been going on for 12 years now. So be thinking about that. But when we're talking about capacity building, it's research capacity building at its core, even though that has some nuances. And implementation research is absolutely a part of that.
All right, I think we have time for a couple more. Are we allowed to state how many applications will be funded through this NOFO? I'll just start out by saying we do not target a certain number of applications. We do not have set aside funds for this. Institutes fund according to their pay lines, and so it's based on meritorious awards. Brad, I'm reminded though of another question that came in offline about ESI considerations. I wonder if you could talk about early stage investigators.
Great. And so this R01 and an R61 R33 is also an R01 equivalent award. So if this were an R21, you're not utilizing your ESI status for that. You use it for the R01 equivalent awards. So ESI will absolutely be considered. When we have our special emphasis panel that reviews everything, we split up the applications to be more established investigators, and then the applications that are dealing purely with ESIs. And we try our best. We sometimes get many applications for these programs. We try our best to pull in the AIDS applications as well to the best of our ability and do all of the ESIs separately so you can have a really appropriate comparator group to within review. Well, I guess not comparator group as much as being reviewed through the mindset of ESI status. And then you do get your ESI bump for this. And that ESI bump if, for instance, your institute that you're applying to has a 10% pay line, then the ESI bump would mean that for ESIs, as long as you are within the 17th percentile, you're getting funded where everybody else is at 10th percentile. So ESI status absolutely applies here for this, and it's for both the R61, R33 as well as the R01.
And those numbers are made up, so definitely
completely made up numbers. Yes, they change every year.
Maybe we will use this as a last question or second to last, probably last question. Can we include vaccine administration as part of the project? Well, we'll do two. Can you talk about review process? Okay, so I think Brad did just talk quite a bit about the review process. Why don't you do the vaccine administration question first?
Sure. Okay, so vaccine administration, and perhaps you're talking about like HPV vaccines. I don't know. I'm just guessing here from the chronic illness of a cancer associated with prevention by a vaccine. Not sure if that's what you're working on, but typically we would not be working on vaccines more broadly because one, the implementation is handled by other organizations often and very difficult, very expensive. And we deal mostly with chronic illnesses. Most chronic illnesses aren't handled by vaccines, although I'm giving examples of ones that are. So it really depends on the context here. But if you are wanting to study the implementation outcomes overlaid with a vaccine rollout for the multimorbid nature of prevention, then we need to move away from that idea. A lot of HPV vaccination would be focused on prevention, not management. So remember, the focus is on management. So I'm not quite sure which vaccines you'd be wanting to roll out for this. Oh, okay, sorry, HPV and Hep B. So HPV from the prevention perspective, more so. This is a question where we would want to dig into what you want to do and the kind of implementation research that you would want to assess. We pull in one of our colleagues from NCI. We don't have NIAID as somebody that would often handle Hep B on the call or for this funding call. So we'd have to do some thinking around its fit. And of course, so often we don't have a hard yes or hard no. It's in this murky middle, but we'd want to have clarity on that. So we can set up a call around what your ideas are and if that would be appropriate, but it's going to be a stretch.
Yeah, I think this other question as well, and I see that we're at time, so I do want to note that there's another question as well about prevention of cognitive decline and mitigation of consequences of dementia. I think all of these questions that really get into the nuances of responsiveness around the research question, those are great opportunities to reach out and to just have a follow-up conversation about the nuances of your specific question around that, because they'll just be most specific to you. So I might just kind of cap it there. Brad, I don't know if you want to say anything else about that.
Exactly. This is the first step of multiple to come over the next coming months. We do remember we have not one but two receipt dates for this call, and we've timed those receipt dates very specifically to give you the opportunity to resubmit your application. But that first application is coming up soon, so be very mindful of that application deadline. Be talking earlier is better with the different points of contact to really make sure that your ideas are going to be germane to the institutes and centers that are going to want to fund these. Setting up those calls early, that can involve Amanda and me, certainly because we have knowledge of the program writ large, but that does not negate the importance of you reaching out to the points of contact that are listed in the NOFO.
Absolutely. Great. Well, thank you so much, everyone. Again, as a final reminder, the slides and the questions will be posted on the website. Our contact information is there. You can reach out. We're really eager to see the applications come in for this program.
Great. Take care, everyone.
Thank you.